3 years back and was not seeing in that eye since then. Let me take you through what was going inside my head. The cataract's lens looks displaced. Is it subluxating? Well, there's no evidence of phacogenesis. Then maybe the lens matter could have been partially absorbed, giving the pseudo-subluxated look, right? What is the status of anterior capsule and the posterior capsule? Can't tell presently. Is there any vitreous disturbance? Again, not sure about that. Well, the B scan is normal, but there is something interesting in the A scan biometry, an unusually deep anterior chamber. If there is no subluxation, then this could possibly indicate the presence of a pre-existing posterior capsule defect. My goal would be to preserve the anterior capsule and the posterior capsule if possible, which would ensure that I can place a posterior chamber lens either into the bag or in the sulcus. And in the worst case scenario, I would have to go with an iris flaw lens. Now let's see how things turn out. After creating the side port, I am staining the anterior capsule with very little amount of trypan blue, hoping that it does not go posteriorly and obscure the red glow subsequently. I decided to make 0.8mm scleral tunnel instead of my regular clear corneal incision during handling the capsule.
I'm sorry.
No. I have loaded it, this thing if you want.
1 minute, let's see. I'll just give it a second shot. Huh?
Hi, this is Dr. The anterior capsule turn out. After creating the side port, I am staining the anterior capsule with very little amount of trypan blue, hoping that it does not go posteriorly and obscure the red glow subsequently. I decided to make a 2.8mm scleral tunnel instead of my regular clear corneal incision. During handling the anterior capsule, I will get information about the status of zonules. As a puncture, well, I don't see any wrinkling that suggests that the zonules could be quite alright. And also, as I start tearing, the anterior capsule tears quite easily. My goal is to achieve a 5mm excess, and I think this is good enough. So far so good. Now since I'm not sure about the status of the posterior capsule, I don't do hydrodissection. I'm just trying to nudge the nucleus around and try to figure out whether the PC is intact. I'm injecting OVD behind the nucleus and also to nudge it to the side so that I can have a view of a possible PC tear. And in just a couple of seconds I could find what I anticipated. This thin line is most likely the edge of a toned posterior capsule. So my strategy now would be to mobilize the nucleus out of the bag and try to emulsify it in the anterior chamber and then place a multi-piece intraocular lens into the sulcus. Using 2 Sinskey hooks, I mobilize the nucleus into the anterior chamber and push OVD both in front and behind the nucleus with the endothelium. At this point, I am certain that there is no vitreous prolapse. I begin emulsifying the nucleus, and after phacoing some part of it, I decide to use the IOL scaffold technique popularized by Dr. Amar Agarwal. This would help preventing any lens matter dropping down into the vitreous cavity. Again, under the cover of dispersive OVD, the nucleus is gently manipulated towards my right side of the anterior chamber. So now with a clear view, I proceed to implant the lens, and then the multi-piece lens is gently manipulated into the sulcus. Now before emulsifying the nucleus, I want to confirm the absence of any vitreous in the anterior chamber by using triamcinolone, and once it is confirmed, I proceed to emulsify the nucleus as slow and as gentle as possible. Now is my time to remove the OVD both in front and behind the lens. At this moment, I become suspicious of some vitreous prolapse. Again, I want to confirm it by using diluted triamcinolone acetate. At this point, I'm not sure about any vitreous prolapse. I still decide to proceed with antivitrectomy since I needed to remove the OVD which had gone behind the posterior chamber into the vitreous cavity. In a couple of minutes, limited antivitrectomy is completed, And now is the time to fix the lens in the rhexis. I ensure that both the haptics are over the anti-capsule, and with the irrigation running through the cannula, I use a lens dialer to gently nudge the optic posteriorly to achieve the optic capture. It is done on either side so that the entire optic moves back behind the rhexis margin. The ovalization of the rhexis confirms a perfect optic capture. I'm injecting triamcinolone acetate one last time to rule out any residual vitreous prolapse. The hydration of the ports is done. Eventually the patient did quite well. He was indeed very happy with the post-operative visual outcome in this traumatic eye.
Thank you, Deepak. That was a brilliant video and wonderfully handled case. But Dr. Shin, would you attempt to do something different, especially in a diseased bag like that, or would you do the same, or what would your recommendation?
Yeah, this video is so nice, beautiful, and maybe I do the same, use the same technique. If I can, I will divide the nucleus using 2 hooks, if I can, before using a phaco. But if not, I do the same.
Which 2 hooks, if I may ask?
Fake chopper.
Okay, just
Yeah.
choppers. Fantastic. Anybody else on the panel? Anybody wants to comment on?
So, beautiful surgery. Congratulations. I think it's a great way of doing it. The only suggestion I would have is perhaps before you actually try to bring the nucleus out of the bag to check whether the posterior capsule is intact or not, I would assume it's not intact perhaps, and to cover that I might just put some dispersive viscoelastic around to try and cover that, and then go ahead and try and phaco it within the bag. Because the key question then comes, did the capsule, was it ruptured initially, or did it rupture in your attempts to manipulate that nucleus?
No, sir, it was pre-existing.
Sure.
And we, the idea of just trying to nudge the nucleus a little bit aside to just identify the rent. I could
No,
see
the question, does it
rent-
matter if you identify the rent at that stage, or is it better you cover for it and then take the nucleus out
Yes.
as you would normally do? Because the whole nucleus came out pretty, it's in one piece, it's like a chalky, consistent approach. That's just it's a thought, you know. Cases like these, you can never extrapolate from one to the next.
Dr. G?
I would not have, I would have put the IOL at the first go rather than.
Yeah. I thought the nucleus was too soft. I could manage it well enough. So
That is
maybe
only difference.
that's the only
Otherwise-
thing.
I've seen traumatic cataracts where the capsule has been ruptured at the time of trauma. And typically what we would see is if you did a UBM, you'd see lens opacity in the anterior vitreous.
Yes.
So I'm surprised that if this was a pre-existing rupture following trauma, that when you lifted up the nucleus, the vitreous was very clear. And in fact, when I first saw this, straight away I said to Jagat here, this is a Morgagnian cataract, where the cortex is already liquefied and has been absorbed. And even these cases, we can see some of the lens material leach into the back of the eye through an intact capsule.
Yes,
Yeah, but I've done, in fact, a case of live surgery where I did a Morgagnian cataract. And when I phacoed that nucleus and I picked it up, actually it behaved like a posterior polar cataract because it was adherent because of the long-standing nature of that cataract that was hypermature, and because of the inflammation that's ongoing, it actually gets adherent. And so what could have happened was that when you visco-dissected this nucleus, it was adherent, and basically it's like visco-dissecting a posterior polar, and you can rip it. Because the anterior vitreous was too clear to represent a previous rupture.
There was some amount of white matter. I think you just missed there. In one of the next when I'm trying to manipulate, and there was some amount of lens matter there.
Yeah, so sometimes you can get that even with a hypermature cataract
ma'am.
where it leaks backwards.
Yeah, it explains. We see cough. Thank you.
Thanks.